do you build a high-performing culture? This is Culture Architects. Candid conversations with extraordinary leaders sharing their biggest successes, failures, and lessons learned on their culture journeys. Here's David J. Friedman.
So welcome to another episode of Culture Architects. So this is a really interesting interview with Dr. Anthony Mazzarelli, also known as Mazz. And the background to this is that Mazz is the co-CEO of the Cooper Health System in Southern New Jersey. And I, as a patient, have been to a number of different Cooper practices, and I noticed that, boy, there's something different going on here. Because any of us who've been to medical practices know that most of the time you're in the waiting room for 50 minutes and then you can't even see anybody and they don't spend any time with you. And every time I go to a Cooper practice, it's just a completely different experience. And it caused me to say, there's something happening here that's purposeful. And I wanted to know who's behind all of this. So I asked a few questions and I was told, you got to talk to Dr. Mazzarelli. He's the man. And so that's what led me to talk to Mazz. And so we're going to have a really interesting conversation. He's got a fascinating background that we'll tell you more about. But for the moment, welcome, Mazz. Appreciate you being on the podcast with us.
Thanks for having me.
Oh, you bet. So Mazz has a really interesting background here in that not only is he a practicing physician, he's an emergency medicine doctor, but he also has a law degree. He also has a master's. He's in administration. This is a guy that's done a lot of things. So bring me back to the beginning, Mazz. So what was your first desire? Were you trying to be a doctor or trying to be a lawyer, or how did this all take place?
No, so it fits together a little better than it sounds when you lay out things like that. But yeah, the first thing I want to do is I always had wanted to be a doctor. So I grew up the son, grandson, and nephew of chiropractors who loved what they did, loved seeing patients. And so I knew that being in healthcare is what I wanted. My grandfather had sort of encouraged me. I kind of thought I'd probably go into chiropractic to have the same experience they did. My grandfather, while loving the field of chiropractic medicine, said, well, don't limit yourself. Go to medical school and maybe you could always go back and learn chiropractic manipulation, figure out which field you like. And so I went right from college to medical school. And in medical school, very early on, I became really interested in bioethics and policy and sort of had this feeling that I really wanted to see patients, kind of what I would call retail medicine, but that I liked the wholesale medicine as well. How can you sort of change the system or affect multiple people at any one time? And so while in medical school, one of the deans who ran a small group class I had was really encouraging multiple degrees. And I met with him and said, I'm thinking about doing a master's in public health because I have this interests and all these different interests. And he said, well, why don't you go follow someone who has an MPH? And so I did. And I came back and he said, what'd you think? And I said, that was really interesting. So, most of the rooms this person was in, it felt like the lawyers made all the decisions. And he said, well, then why don't you go to law school? And I said, that's crazy. He said, well, it's not that crazy. We'll work with whatever law school you get into. So I was able to do all these degrees in six years. So save a year by doing them all together. And in some sense, save 2 years because of the master's in bioethics, where I ultimately went to school. I got that as well at the University of Pennsylvania. And so that's kind of how that came about. And then I went in, did my residency in emergency medicine, knew I wanted to see patients, thought I would write about academic medicine and write about policy and bioethics and teach. But I got pulled more and more into administration. I like fixing things. I like process improvement. To me, that's treating not just patients, but treating an organization or treating a group of people and seeing people be able to do their jobs better. Because a lot of the things I fixed at first were the things that surrounded me and my fellow residents or my fellow physicians. And I just got drawn more and more into the world of administration, but still kept an academic interest in a lot of these things. And that ultimately led to what I do now.
Wow. And so what caused you to, I get you got this background in looking at fixing systems and not just, individual patients and things. So where along the line did this whole idea of working on the culture of an organization come to you?
I can tell you exactly where it came from. Right. So I can pinpoint the moment.
Okay.
So when I became CMO, I'd always sort of figured out people are the most important thing. I had great mentors and leaders And the common thread of all of them is they focused on people. And in some sense, they focused on people, meaning they had a very intentional culture around them. Mm-hmm. I don't think I would have been able to put my finger on that at the time. But when I became the chief medical officer here at Cooper, this is 2013 or 14, my boss at the time, the CEO, Adrienne Kirby, she said, look, there's two things you got to do. You have to improve patient satisfaction and physician engagement. That's what you need to do. That's your job. And I'm going to help you. I'm going to pay lots of money to a consultant who's going to help you pull this off. So I said, great, I'll take any resources I can. Because I was kind of new in the job. I was the youngest CMO we ever had. So I meet with this consultant and they give me a list of things that they say we need to do. And that list of things worried me. It felt really mushy. It was like, sit down while you're talking to patients, say thank you, always introduce yourself a certain way, do this list of very soft, what I used to call soft skills. Mm-hmm. And I thought, I'm never going to get 450 faculty members, at the time. Now we have 850 to do this. So I called our top NIH researcher. He was a guy that did resuscitation research, published in every journal. He basically studied people that die and how to make them not die at the end of life. I mean, he did hardcore research. And I said, his name's Steve Treziak. And I said, Steve, I need you to be my guy for the mushy stuff. And he said, you're nuts. I'm this, no, I'm a hard researcher. And I said, yeah, but I need you to science this up. Go see if there's any literature around this. So he goes and he reviews the medical literature and comes back and he goes, I thought you were crazy, but there's some data out here that doing that connecting more with patients, leaning in with patients, more compassion in that interaction actually has pretty profound effects. So we got really interested and we actually combed the entire biomedical literature, every paper that existed on this topic. And what we found was that if you better connect with patients when you're a care provider of any type, you improve outcomes, you lower costs, and you decrease burnout. Mm. So it's actually better for the people who provide the care. So then we wrote a book about it.
And in doing that, Compassionomics.
That's right? Compassionomics. And then in writing that book, we said, come on, can it really be that only people who are in healthcare get the benefit of helping others and focusing on others? It has to be everybody, right? Let's pull that bit of data. So then we pulled together every single article about focusing on other people. And what we found was that if you are someone that spends time focusing on other people, and you don't have to quit your job or change, move, but if you think about other people and the way you do things, you'll live longer, you'll have better health, you'll have a better career, the teams you lead will be better, you'll have better outcomes with respect to what you want to do professionally. And then you start to see how what that really speaks to is what leaders do and having a culture where people support each other. Yeah. So then when I was able to, and so that we wrote our second book about that, Wonder Drug. And so that's that sort of those two things together, those that made me realize, hey, if we create a culture where people are very focused on others, that's going to be the key to have people really like what they do for a living. And the experience of our patients will be better. And then I know their outcomes will be better as well. So that's how it kind of all came together. Now, we are nowhere near, that's the why. We are nowhere near the how. I am so thrilled that you had an experience that shows that this is, that we're starting to do it. Multiple experiences.
So there's some consistency there.
No, I appreciate that. And we're trying to get there because it's amazing what it will do, not only for patients, but also for people that work here. And there is a war for talent right now. Yeah. So you have to make sure people like what they do, feel purpose in what they do, feel supported. And so we wanted to make sure, Kevin O'Dowd, my co-CEO, and I, very important to us to be servant leaders, have our teams be servant leaders to their people, and to really focus on the people that work for you in the organization, and that the closer you are to the work, the more important you are in the organization, and that all of our jobs are to block and tackle so people can spend time with patients and give you the kind of experience you talked about.
Yeah. It's interesting. I had an experience a year or two ago. I was doing a talk and I happened to be at a Ritz-Carlton. And of course, Ritz-Carlton is known for extraordinary service and extraordinary culture. And I was because I've learned a lot from them and patterned a lot of the work that we do after Ritz-Carlton, I was doing some field research while I was there. I figured, hey, let me talk to some people here. And so I was in the restaurant and I talked to the waiter, asked him how long he had been there, and he'd been there like 10 years. And I said, tell me a couple stories of things you've done here that really stood out in your mind in terms of serving guests that you probably couldn't have done somewhere else. And he told me a couple stories. And what I noticed about it, and this gets to your point, what I noticed is the way it affected him. Forget how it affected the customer, or in your case, patients. It affected him. If you're the kind of person who loves to serve, what a wonderful thing that you get to serve, that you get promoted, for serving, that you get celebrated for serving. It's satisfying. And conversely, if you're somebody who loves to serve, it's frustrating as all get out when you're stifled in your ability to do that. And so same thing, exactly what you're saying. If I'm a physician and I really want to help people and I really do care, it's got to be, one, frustrating as heck when I can't do that. And on the opposite side, rewarding and refreshing to be celebrated for and encouraged to do the things that I really deeply want to do.
Absolutely. And this is becoming a bigger and bigger deal in medicine where, physicians, here's my take. I think physicians see patients for free. They feel like they get paid to do paperwork, right? And that all the administrative stuff that goes around them. So we're constantly trying to, hey, how can we take some of those administrative tasks off? What can we do to lower the cognitive burden on administrative type tasks so they can connect with patients? Yeah. And that's what's going to create the culture we want, that focus. And they're going to like what they do.
Yeah. So let's go back to, okay, got the theory. That all makes sense. You figured had this intuition. You got your partner to science it up, as you called it.
Yeah, and then we wrote the book together.
We wrote the book together. And I did read that book, Compassionomics, which I will tell the audience, great book, very well written, plain, simple English, well described, really quite a good book.
I'm impressed because really we wrote Wonder Drug for people who are not in medicine, which summarizes Compassionomics and then gets into the things how people can apply it to their life. Compassionomics is dense, written for healthcare workers. So I'm impressed that you got through it.
I did not find it to be dense at all. No, I didn't think so. I thought it was explained in pretty simple, straightforward English. Anyway, so I would encourage audience members, check out Compassionomics for sure. It does make the science case, as Mazz is saying, for the fact that being compassionate actually impacts in so many different ways. But here's my question. So, you wrote the book with your partner and you're a believer. The science tells you that what your instincts told you is actually true. Okay. So now you've got how many hundreds of physicians. Yeah. And you've got to somehow in a complex organization like that, figure out, okay, I got this idea. How do I architect that? Well, so how'd you do that?
It's interesting because well, first of all, it's a journey, right? We're not done. And so, but it's interesting because if you think about it, what I'm basically saying is we already had the how. I had a list of things that they were to do. That these sort of tips and tricks and how to connect more with patients and how to ask your questions. These are things that we have been teaching in medicine now for several years. Okay. The idea of connecting more with patients and more compassion actually has been slowly infused in the medical school curriculum over the last several years, but no one does it consistently. Right. And so what we really sought out to do is the why. If we can tell people why they need to do things, they will more consistently do them because everyone agrees like we ought to be doing these things, but it's not it. But how can we make it be in the evidence-based realm? That was the whole idea of this. This is evidence-based medicine, just like other things are. And that there's actually science in what people think of as the art of medicine. Right. And these things that we've been telling you to do, get them down, do them well, and your patients will benefit and so will you. So really it was just a motivation of the why to do the things that people have been told now for a while to do. Now, the problem is that in medicine, we tend to think of it still a little bit too much as dessert, right? Mm-hmm. Like, well, if after my main course, if I still have some room in my stomach, okay, I'll have dessert. Like, yeah, the most important thing is I save the patient's life and I do all these things and then I'll worry later about the way I interact with them. But it turns out you have to do those things together and it doesn't really take any extra time. Yeah. Well, so first we're able to do that better. We still have a long way to go again for our physicians. And then it was, well, how do you make that case for people who aren't seeing patients, right? We have 10,000 employees. And it turns out it's the same way, only it's every opportunity you have to think about what you're doing serves other people is a benefit. So our mission is to serve, to heal, to educate. And we say, look, that service is not just to our patients in the community, that service is to each other. Mm-hmm. And there's lots of great studies about people who can achieve a culture where people are very supportive of each other, that the absenteeism goes down, turnover goes down. All the metrics you already wanted to measure all get better when you do those things. And so then we had to turn to, okay, well, all right, maybe we're getting some of the physicians on board for this. And we would tell them, look, these are the metrics. It's all, a lot of culture is also having clear goals, right? And metrics and data. All right, well, these are the things we're judging you on. We're telling you the best way to get there is to lean into patients. It's the way you treat each other. And it's the same thing for the rest of the organization. And so over time, by the way, we never told anyone about the books. Mm-hmm. Like it's funny, it's not in our bookstore. It's not, it's because it's the ideas in that we've been preaching. You can't go around and say, hey, we want this organization to look down the org chart, not up it. Don't boss watch, think about your people, and then tell them, hey, read my book, right? But it's the principles that we try to infuse in the different things we do, and in the way that we try to treat each other, in the way we have managers and directors think about how they solve problems for their people. And again, we're getting better at it, but that's what we're trying to get down. That because really, when someone has an issue at their job and you make their job better, you've taken their pain away. That's compassion.
Yeah.
And that's the culture that we want to have and are trying to get to. But it's difficult in any organization. Healthcare, though, is incredibly complex, and there's a lot of moving parts. And so we often hide behind that to say why it maybe isn't so great to work here, or why things are so hard, or why we can't do that for the patient. We're trying to break through that to really to have our driving force be, how do we connect more with those that we serve, whether they be patients or each other?
So when you started doing that, I mean, I hear you that if you give people the why, they understand the purpose behind that.
You got to give them the how then too.
You do, because at the same time, I mean, if I think most people would know why they should lose weight or exercise or stop smoking or whatever.
But how?
But most of them, and even if you gave them the how, most of them don't do it successfully. So there is some structure behind this.
There is. Oh, sure.
That's necessary. Tell me more about what did you put in place structurally?
Yeah, we have these things. So we have things we call the Cooper must-haves.
Okay.
So one of them is rounding. If you're a leader, you need to walk around and interact with those that you lead and patients.
Okay.
If you're not in an area that has patients, if you're in the back business office, you need to walk around, you need to round.
Okay.
And we track that and we look at that. You have to achieve a certain percentage of time that you round and meet with your direct reports in order to achieve certain goals. And there are things tied to that. So that's very important now. So rounding is, I'd say it's probably towards the top.
Okay.
One of the things we also do is we collect what we call stoplight report issues. We collect issues from, we have everybody, who rounds around the organization, all of our executives round around the organization. And when they round, they're very purposeful in what they do. It's not just saying hi, right? It's this idea of also collecting issues. What are we doing well? That's great. Talk about what's going well. And then immediately get into what could we do better as an organization. When we collect these issues, we actually have an entire software system where when you put an issue in, you log that stoplight report issue and you put in who you think is the resolver. So let's say someone says, this computer never prints, the printing's always off. I call IT, they come all the time. Then you might put in, on what unit you're on, you put in, there's an issue with the printer, and then you make the resolver, let's say IT. Well, now the head of IT, the top head of IT, that person now is going to get, every week or so, is going to get pinged to make sure that they either take that issue, which is now yellow when you think about a stoplight, and either turn it red and say, this is why something can't be done, or fix it and turn it green. And those issues by department, we hang in that department and everybody can read them.
Wow.
Right? So, and by the way, we didn't create this. This is an evidence-based leadership model. Just like we try to be evidence-based in what we do with patients, we try to be evidence-based in what we do administratively. So you can imagine, now if you, in any single department, if you go over, you can look in the break room and you can look at the stoplight report and what are the things Cooper's turned green? What is what are the updates on the yellows and what are reds? And I always tell people, look, a good red is as important as a green. In other words, yeah, I know you think this should happen this way, but we looked into it and it's illegal, or we can't do it, or this is why we can't do it. And I think that engages people as well. We want to earn the benefit of the doubt. I'm always telling that. We're always talking about that with our leaders. Like, you want to earn the benefit of that. You want people to feel like if they work here, we're either going to listen to them on the ways they think we could do things better, or we're going to have a good reason why we don't. And so I can look, if I just look at rounding numbers and how consistently they use a stoplight report, essentially from those two things, I can tell which departments are going to perform well. I mean, and the ones that don't, they're not doing those things as consistently. Yeah. It's pretty obvious. And then that trickles down to the patient experience scores as well.
Absolutely. So when you first rolled out some of these things, the rounding, let's say, and the stoplight report, were people on board right away, or were people saying, what kind of crap is this, Mazz? What's he coming up with this stuff for?
Of course there was resistance, right? There are incredible amounts of, and everybody, an organization that's a larger one like ours, and there's obviously much bigger organizations, everybody just thinks they'll just ride it out, right? Like, because they've seen the flavor of the month managing technique before. So that's why we just have to be consistent. And of course, I'm sure there's still people who still feel that way, right? But when you start to see people who continually to high perform, we also make it a point to point out to those high performers why we believe they're high performing. And it's always because they're doing the things that we say are the important things to do, and then highlight them to other people. We'll tell people if they're not performing well, go talk to this person over here. And it's always going to be, it's because they round and they do the must-haves. We're big into gratitude. So, consistently writing thank you notes within the organization to each other and things like these things that sound sort of corny. They're evidence-based in what they do. Yeah. It doesn't matter whether you're the kindest person in the world or you're someone that's only out to succeed for yourself. They're still the things that you should do if you want to get ahead.
Absolutely. And so if you look back at some of the things that you've instituted over the last, so it's been like since 2012, 13, 14 that you started to do these kinds of things. So we're talking 9-10 years.
Well, it's 9 or 10 years. I ran the physician group until 2018.
Okay.
And then Kevin and I became co-presidents and then co-CEO. So it's been about 4 or 5 years.
Okay. Got it.
When you think about being able to institute it across the whole institution.
Got it. So 2 questions. One, what are some of the statistics? You mentioned that if you get people doing these kinds of things, you're going to have better patient outcomes. You're going to have greater satisfaction among your employees and physicians. All these positive things happen. So what are some of the statistics that you might cite for how Cooper does better than perhaps the average in healthcare? In other words, if average healthcare turnover is X, Cooper is X minus something, or if engagement is Y, Cooper's. Give me some of those statistics. Sure.
So our physician engagement scores went from, if I had this right, the 25th percentile to the 46th percentile to the 55th percentile to the 60-something, 70-something, and then 80th percentile. So we saw that rise up, right? Our engagement scores in our ambulatory offices, so that's over half of our business, same thing. It was consistently applied. We had a leader there that was, by the book, and those numbers for engagement, went from the 20s to the 30s to the 40s to the 50s up to the 60s, and that's where they are. In the hospital, where we started a little bit later, so we're still on that journey. So those are our engagement scores from our people. And then if you look at our patient experience scores, those have gone up also over the years in the same way. But, if you measure the metrics that you would measure any company on, aside from those, if you look at our revenue, our margin, all of those things have gone up as well. I can't say those are from these concepts.
Sure.
But I don't, it may have it probably plays some role in it. I mean, I would say if you really ask me, it's our leaders. We have incredible leaders. It's certainly not Kevin and I. We'd be the first to admit that. We have a board that has had a vision for what we would do. And we've been able to hire leaders that really block and tackle for their people so that they can interact with patients and like what they do. And that's really been the secret. So, but a lot of those measuring sticks are the things you would look at. Healthcare is in a really tough spot right now. Health systems had on average, a negative margin in 2022 for the first time ever. So health systems, last year was harder than the first COVID year for health systems because expenses are kind of crazy out of control. And we were lucky. We didn't have that. And we had a double bond rating update. So things are going well right now. I certainly don't think, like I said, it's Kevin and I think it is the consistency starting with the leaders who came before me, a consistency of looking at, of not having these must-haves be a flavor of the month. And over time, and again, we still have a long way to go. I think that's at least part of what's happening. But we have great people. The physician leaders here, a lot of them have been here for a long time. They're people I learned from when I was a student and a resident. And they're so focused on this being a special place for people. We really do. And as our vision says, we want to be the best place to be a patient, to work, to practice medicine, to learn medicine. We want this to be the best place for all of those things.
This is a good spot for us to take a break from our conversation with Dr. Anthony Mazzarelli, or we call him Mazz. He's the co-president and CEO of Cooper University Healthcare. In our next episode of Culture Architects, Mazz and I are going to unpack his learnings from his years of leading the Cooper Health System. And we're going to talk about culture building within the context of what has certainly been one of the most disruptive events in the healthcare industry, the COVID-19 pandemic.
This has been Culture Architects with David J. Friedman. Join us next time for more insights and wisdom from great leaders in all walks of life. To book David for your next event or to learn more about his writing, speaking, or consulting, go to davidjfriedman.com. Culture Architects with David J. Friedman is a production of CultureWise.